Warm good afternoon, everybody. I welcome you all to this instruction course on topical Phaco, golden tips to make life easier for the surgeon and the patient. It's basically intended to encourage more people to take up topical Phaco emulsification. Most of the time, it's a mind block rather than anything else, which prevents you from starting topical Phaco emulsification. So certain things, many times people start doing the surgery and then later on with the first slightest difficulty, they go back to the block. And most of the time it may not be the surgeon's capacity or capability, but it may be something wrong which happens, which is totally unrelated to the surgical procedure, etc. So we have wonderful speakers today. I'll be talking to you about patient positioning, surgeon positioning, wound construction, etc., which are all very important things. And nucleus management. Dr. Sandhyayan, who is a senior consultant in Phaco and UVA at Giridhara Institute, will talk to us on tips to make nucleus management easier. And we have Dr. Matthew Johnson, who is a senior consultant at Mothercare Eye Hospital, Mothercare Hospital in Palakkad, Mannarkad, on making IOL implantation easier and perfect. He has been practicing topical Phaco for a very long time, and one of the few people I've seen in government service who has used the Centurion and doing topical Phaco with foldable IOL for almost quite some time. And then we have Dr. Matthew Kurian. He doesn't need an introduction. He's a senior Phaco surgeon and medical superintendent at Chaitanya Eye Hospital, formerly of Narayan Nethralaya, on converting to SICS in a do-or-die situation. Tips to make Rexus and hydro procedures easier by Dr. Anish Madhavan, who is a prolific cataract surgeon at Kollam. And we have our international star, Dr. Minu Mathan, who talks about PC run during topical Phaco, how to go ahead. And this is followed by a panel discussion. So just to start off, patient positioning, surgeon positioning, wound construction, etc. So your surgery, the preparation should start much earlier than the surgery time. So, one second. So here is the patient just walking in. He is on a wheelchair. So patient is very apprehensive. So you are sitting there, one smile at him and just asking him an encouraging question may help him a long way, because see, he is coming in and when you speak something, he smiles. So that is very important. So you just tell him it will be all fine. There won't be any pain, etc. Makes him more comfortable. And positioning the patient, again, is very important. Most of the time, in topical Phaco, even the slightest movement of the patient's head or the eye, etc., can cause a lot of difficulty to the operating surgeon. So positioning is very important. At times, the patient will be to one side of the table, and you will be sitting at the other side. So literally, you will be like leaning forward and doing the cataract surgery. Or there may be a gap always between the head and the head end of the headrest and this thing. And that gap also, if you're sitting superior, it can cause a difficulty. So ideally, the position of the head should be perfect so that your microscope light comes at 90 degrees to the eye. So to make that, make sure the patient is positioned very properly in the beginning of the surgery. And see, this is what I am trying to talk about. The patient's head is somewhere here. There is a gap here, so the patient has to be shifted up. And then always make sure the head is positioned not to one side. And patients always tend to keep moving to one side. So if you can do something to prevent that, either by a tenicoid ring which is fixed there, or to use a sheet so that they don't move to one side, it will be a good idea. Next is about the patient, the surgeon positioning. You have to make sure spend some time and sit properly in the correct position. Usually if I am a left-hander, so if I am operating a right-handed patient and if I want a supratemporal section, I would sit temporally, and vice versa with the right-handers. When I want to do left eye, I sit superiorly, so I get a supratemporal incision in which you get the minimum amount of astigmatism. Nowadays with 2.2 incision, it hardly does matter, but that's one this thing. And this is again what you do while you adjust. Again, look at the head position and see through whether the chin is sufficiently raised or the chin is down. All this makes a huge difference. The system must have adjusted, but then still, again the patient will go down. So try to adjust and keep telling them at this time, talk to them at this time, it will make a difference. So when you apply a speculum, it shouldn't be too tight. Most of the time you think it's only a tight speculum which causes eye pressure and positive pressure, but even a loose speculum can cause pressure on the globe. Because especially if it is hard, the speculum is a hard one, obviously you will be using self-retaining specula. So if you feel there is a positive pressure, try and adjust the speculum. So the easiest way, always talk to them while applying the speculum also. Just ask the sister to retract the lids and then place it. And by careful positioning, and the patient also will give a hint. If it is too tight, he will also wink. Yeah. And what I do nowadays is a saline wash. So this helps in patient training. You tell the patient not to look up, down, look at the light, but when saline falls, they automatically have a Bell's phenomenon and go up. So while you inject, one thing what happens is, you know that the patient, 2 syringes of fluid randomly onto the cornea, in center of the cornea, so that the patient, you know how much the patient will be cooperative in that. Again, if there is a pooling while you put this, you can adjust the head position so that the head is not turned to one position. And what I have found, the past 1.5 years I've been doing it, the amount of corneal edema, postoperative corneal, is dramatically reduced because the possibility of a mild TAS happening in these patients. So this is what I am talking about. This is the external view in which I'm just washing, keeping on washing, and you see this patient is cooperating very well and looking. And so it's a kind of training to the patient. You wash once again, and by the end of the procedure, patient is tuned for the surgery. And this is about holding the instruments. Okay, it should be ideally a pen hold, and then if at all you need to stabilize your instrument, stabilize it in such a way that you can use your little finger or your fourth finger to stabilize and then enter into the eye. Always make sure if you are accidentally pressing on the other eye, then the patient you will not know what is happening, patient will suddenly start moving. So this happens to be many times. If the other eye is operated, I'll make sure there is a shield which is kept so that the patient does not have a problem. And wound construction, what I would say is, try and avoid holding the conjunctiva, because postoperatively you will have a very quiet eye and there will be minimum postoperative irritation, because there won't be any Dellen formation, things like that, and the patient, the eye looks very, very white, and there is a short video of that. So this is again a microscopic view of how you wash. Tell the patient to keep looking at the light. And when that is over, you can start making the incisions. So generally I don't touch anywhere. So you can, if you want to stabilize, you can use the shepherd's ring, but of late I have stopped that also. I use the sideport knife itself to stabilize it. Just enter it a little bit and then make the main section. And patient will cooperate because then the cornea is anesthetized. Then using both this thing, you make the entry. So you don't touch the conjunctiva anywhere, and conjunctiva will not be as well anesthetized as the cornea. So this is how the patient cooperates very well. So in summary, if you take care about the patient positioning, your positioning and minimum touch techniques, you will end up doing a good surgery, and your conversion from peribulbar to a topical clear corneal will be very easy. Thank you very much. Now, the next talk will be by Dr. N. Sandhya. She'll be talking to about tips to make nuclear management easier.
Now we have discussed about wound construction in topical phaco. We'll move on to nucleus management in topical phaco. This patient had nuclear sclerosis grade 2 to 3. Pupil was dilating well. The microscope illumination was reduced to cause minimum discomfort to the patient. So after a good cortico-cleavage hydrodissection, OVD was injected and nucleus was tapped in the center to release the trapped fluid. Now the nucleus rotation should be very gentle so as to reduce the zonular tuck on the ciliary body, which can cause pain. Now the cornea was moistened with OVD. This can avoid frequent irrigation with BSS solution. When you're introducing the phaco tip, you should not overinflate the anterior chamber with OVD. It should always be underfilled, and you should reduce the infusion pressure because the sudden deepening of anterior chamber can cause stretching of the ciliary body and pain and discomfort to the patient. You can select your choice of nucleus strategy, but here I am doing a stop and chop. Now after about 80% of the depth of the nucleus is trenched, now this was split into 2 halves. During all these maneuver, care should be taken not to engage or touch the iris, which can cause pain. And after splitting this into 2 pieces, each of this piece was then subchopped. That is, the phaco probe was embedded into the nucleus. The probe was lifted up and the second instrument was pushed down, so the nucleus is split and then it is separated laterally. Now during nucleus management, globe fixation is not a big problem because there are 2 instruments within the eye, and so the patient won't be moving the eye too much. And also by this time the patient would have got used to the microscope illumination. Now each of these pieces was brought into the anterior chamber, and then before taking out the phaco probe, OVD was injected so that there is no sudden shallowing of anterior chamber, which can also cause some discomfort to the patient. So the endothelium was protected with dispersive OVD, and then the nucleus pieces were emulsified very carefully. Now there are only 2 situations when you fill the anterior chamber completely with OVD in topical phaco. That is just before capsulorhexis to keep the anterior capsule flat, and also before insertion of IOL. So sometimes these patients can move their eyes, so we should be careful about that. And then these nucleus pieces and the last piece of epinucleus was emulsified. And again, before taking out the phaco probe, OVD is injected, and then the cortex was removed. And in this patient, at the end of nucleus emulsification and cortex removal, there were some epithelial plaques that was attached to the capsule. So the stabilization of globe is very important in this stage, and you should keep the irrigation very close to the posterior capsule so that it doesn't come up and it is caught by the aspiration port. And also you should avoid leakage of side port. Actually there is some leakage, but it should be avoided. Then when the anterior chamber was filled with OVD, patient complained of pain. So I have to supplement topical anesthesia. So here I am injecting subconjunctival xylocaine 2%. So the conjunctival stretching causes severe pain. So you have to anesthetize the area with a paracaine soaked cotton tip applicator, and a small amount of xylocaine is injected subconjunctivally. Then wait for some time and then inject very slowly so that there is no sudden stretching of the conjunctiva. And then you can just push this xylo. You can take it all around the limbus, so that there is the entire area is anesthetized. Now this I have seen in one of the videos of Dr. Saurav Patwardhan, and this works very well. And after that I could complete the procedure without any pain. Now in this patient had a very soft cataract, and the capsulorhexis was done under femto platform. Here there was a small area of attachment of the rhexis, and so that was removed carefully and the flap was taken. And then, since the cataract was very small, it was flipped out of the capsule using very low power, but again it got eaten up, and so I had to lift it up again with the dialer, and then the entire nucleus was emulsified in the epinuclear mode. Now in this patient with soft cataract, the nucleus was prolapsed into the anterior chamber, and I did a supracapsular emulsification. During all these procedures, you should protect the endothelium with a dispersive OVD. And in very soft cataract, this strategy can be adopted in topical phaco because more manipulations can be avoided. So this was a patient with a medicated stent. So the cardiologist didn't want to stop antiplatelet. So even though the cataract was hard and mature, I had to operate topically. So after a careful hydrodissection, since so as not to increase the back pressure, the loose cortex was aspirated bimanually. And then I made a deep central trench and then tried to chop the nucleus. But since I could not crack the posterior plate, so there was this central nuclear button. So once this button comes, then you will have to eat it up. Otherwise, it will block bringing the other pieces into the anterior chamber. So once the disc-like central core was eaten up, then the rest of the nucleus was chopped into smaller pieces. But still, I could not break the central attachment at the bottom because I didn't crack the posterior plate initially. So each of these pieces were slightly pulled to the anterior chamber. Then I just trimmed it above the attachment point, that is the common pedicle there. And by the time this nucleus flipped off, heminucleus, and then it's a safe way is to just reposit it back after filling the anterior chamber with OVD. But here I just lifted up it, and then I am here breaking the central attachment. So whenever there is a common point of attachment, that is a pedicle sort, you have to initially sever that attachment. So then further nucleus management becomes very easy. Now in this patient, I am trying a horizontal. In this patient, I am trying a horizontal chop. So once you can see, this video is not. So once you can see a central red reflex there, you can split the nucleus, and then you have to rotate it into two halves. And then what you have to do is you have to impale the phaco probe into the half. So once you see the red reflex, you can then split the nucleus into two halves. So that means that you have reached enough depth, and then each of this half was then chopped. That is, you have to hold the piece with a phaco probe and then take the dialer under the rhexis margin, hook the equator, and then bring it through the lens to the probe so that the horizontal chopping will be done. So to summarize, we should avoid very hard and intumescent mature cataracts for taking these very hard and intumescent mature cataracts for topical phaco. A good hydrodissection and slow and careful rotation of the nucleus is important. Underfill the chamber with OVD and lower the infusion pressure while introducing the phaco probe. Care should be taken not to engage or touch the iris. Use OVD to moisten the cornea, and also you should avoid sudden collapse of chamber while withdrawing the phaco probe. And glove fixation is less of a problem during nuclear management compared to wound construction and capsulorhexis. Thank you.
Thank you, Dr. Sandhya, for that very illustrative talk on nucleus management. Take-home point will be, although the section will be painless, sudden inflation and deflation can definitely cause discomfort to the patient. And if possible, once you enter with the phaco probe, it's preferable you finish everything and come out. Multiple going in and coming out, especially without replacing with viscoelastic, may be a slightly difficult thing for the patient to tolerate. And whenever necessary, we should augment with either intracameral or, if needed, subconjunctival. Now I request Dr. Matthew Johnson to talk on making IOL implantation easier and perfect. Matthew Johnson is a phaco surgeon at Mother Care Hospital, Mannarkad. And he's been doing topical phacos for quite some time now.
See, once one of my first year PGs came and he was in seeing cases. He came in the end and asked me, sir, 2 cases. You put intracameral lignocaine and waited for 1 minute. Other cases you did not do. Why, sir? So I appreciated her for seeing that. But then it was in high myope patients. So in high myope patients, I always inject a little more of intracameral xylocaine so that it anesthetizes the ciliary body area better. Because even if you lower your bottle height, there is going to be reverse pupillary block and the chamber will deepen more and they'll have some kind of discomfort. So to avoid that, this helps.
That is a wonderful tip by an experienced surgeon. Yeah, so in high myopes, it may be a better idea to wait for a little long. Thank you.
Good afternoon, everybody. My topic is making IOL implantation easier and perfect in topical phaco. So what is in a surgeon's mind while implanting an IOL? There should not be any damage to PC and both haptics should be in the back. We should clear all the viscoelastic from AC, back and behind the IOL. There should not be any CBDS, that is capsular back distension syndrome post-operatively, and after all we should finish the case as fast as possible. So to avoid damage to PC, it can be achieved by visco-assisted IOL implantation or by hydro implantation. But the problem is that once I had faced a case where overinflation of bag with visco it can cause a rupture, PC rupture while tucking in the haptic, especially if it is a plate haptic. This occurs when visco gets trapped between the optic and PC while IOL is forcefully tucked into the bag. The solution is that we should inflate just enough visco so that the eyeball isn't soft. Remember that we have visco inside the cartridge also. But the best solution which I found is that we can do hydro implantation. We have no worry about visco trap or PC damage. And both haptics should be in the back. It can be achieved either by visco implantation of IOL or by hydro implantation. Clear the viscoelastic from AC bag behind IOL. It is a time consuming to aspirate visco from AC bag and behind IOL, but it is the most important for best early post-operative outcome. So is there any way we can skip this step of visco aspiration yet clear out all the visco inside the eye? Yes, by hydro implantation. And prevent capsular back distension syndrome post-operatively. It is due to the visco trapped between the IOL and the bag, which cause a myopic shift in the IOL, which can cause an early post CBDS, which is a myopic shift, and in late post-operative period, early incidence of PCO can also occur. Solution is NDR capsulotomy. Prevention is by thorough visco wash from behind the IOL, but the best method of prevention is by hydro implantation of IOL. And finish the case fast by learning the art of hydro implantation. So the steps of hydro implantation I have written. I'll just go through it and show the videos. IOL implantation without using viscoelastic. Keep the irrigation in on position and inject the IOL through main port with the dominant hand. Irrigation in the non-dominant hand. The visco inside the cartridge gets washed off through the opposite side port. While injecting direct the IOL into the bag, keep the irrigation probe over the inserting IOL as a guide to prevent the IOL from being opened up in the AC. That is an important point. Leading haptic opens into the bag and lagging haptic opens in the AC, and then we can use the aspiration probe in off position to tuck in or dial in safely the IOL into the bag. I'll just show the videos. Old presentation. That is old presentation. So you can see the irrigation is in on position. To the other side port, you can see the water is escaping. So you can see the visco which is escaping through the opposite side port. And I am using the irrigation probe as a guide to direct the IOL behind the irrigation probe into the bag. And using the aspiration probe in off position, I'll just tuck in the lagging haptic. Okay. I'll show a few more videos of the same. I'm using the irrigation probe to guide the IOL behind the irrigation probe into the bag, into the opposite pole of the bag. And the lagging haptic is being tucked in. So after this, there is no need of visco wash. Just take out, seal the wound. So in this case, actually, this is basically the cartridge is in the AC. And I am just, it is very easy if the cartridge is in the AC. If it is wound assisted IOL implantation, we have to have the irrigation probe to guide it. But if the cartridge is in the AC, it is very easy. It will directly go into the bag. There is no need of guiding with the irrigation probe. Another video when the cartridge is being in the AC. You can see the cartridge here. So this is about the hydroimplantation technique. So what happens if I don't use the irrigation probe as a guide? I'll show in the next video. The IOL, since there is no visco, IOL can dance in the AC in the BSS. There won't be, we can't just control where the IOL is going. So we have to actively use both the, sorry, it's not that one. Just, so, see, so the IOL just opens up. So we have to use both irrigation and aspiration cannula to correctly position the IOL and dial it into the AC. One more video of the same. So for the beginners, there is another technique where we can use the visco as well as hydroimplantation. But I found this as the most useful technique, just guiding with the irrigation probe. Thank you.
Thank you, Matthew, for that illustration of hydroimplantation. Yeah, once you're confident, you should be confident about doing it under visco initially. Then, when you convert, you should be quite confident about doing it. You shouldn't be doing it first thing on a clear corneal tunnel. The initial cases, probably you can do visco assisted,
yes,
so that you're more confident, and then you can go.
Yes.
Second thing is, when you inject, if you bend the injector a little bit when the trailing haptic is going in, most of the time it will slip into the into the bag, and you don't need to worry about it.
Sir.
But definitely saving time in a topical Phaco is very important, because we have to finish the procedure fast.
Yes, sir.
So it will go a long way. Thank you so much.
Thank you, sir.
Thank you, sir. Now I call upon Dr. Matthew Kurian to talk to about converting to SICS in a do or die situation, golden tips. Yeah, Dr. Matthew is a very senior and prolific cataract surgeon, ex-medical superintendent of Narayan Nethralaya and now of Chaitanya Eye Hospital. And I was really impressed with one of the videos he showed in AOS about conversion from a tunnel without making a scleral groove and doing the escape. Over to Dr. Matthew.
Thank you. So often when we are doing surgery, especially if you are doing it under topical anesthesia, when you have a complication, you have to have a plan to get out of trouble. And we can of course make a superior incision separately, but what I prefer to do is make my primary incision as a sclerolimbal incision, so that then I can make back cuts and scleral pocket, get a good internal corneal lip, and then have a square wound at the end of it. This cannot be done for the first time when you have a intraoperative complication. You need to practice it. So SICS cases, I typically do sclerolimbal incision or a posterior limbal incision, and then instead of doing a rigid lens, I have this to practice, so that intraoperatively during cases, I am able to convert into a practiced plan B escape route. Pseudo exfoliation, mature, hypermature cataract, and you can see this very leathery hard thing. There is flicker. I feel there is zonular dialysis or zonulopathy. The rhexis is adequate for phacoemulsification. It is not adequate for conversion to SICS. So I am making a small nick, and then using microrhexis forceps, I have then converted it into a larger rhexis, which is adequate to prolapse this very hard nucleus out of the bag. So through the side port, now that I have the things in the anterior chamber a little bit stabilized, I am using a Sinskey hook to gently prolapse. Remember, this is 360-degree laxity with probable zonular dialysis is what I am thinking of. And so very gently I extend it, prolapse the nucleus into the anterior chamber. Things are controlled in the anterior chamber. At this point, then I go into the wound using the same crescent itself. It has to be a new crescent. I do a transconjunctival back cut. The conjunctiva cuts at one point. The sclera is actually at getting incised at a different point. I make the scleral pouches backwards and then extend into clear cornea. Good internal corneal lip is necessary, and then I make the wound internal opening, which is at least almost from 10 o'clock to 2 o'clock or even larger. Once this is achieved well, I can just use visco expression and deliver this nucleus. So it's a very large nucleus, as you can see, and that is it is possible to deliver that using visco expression. I am then now using the planned lens in this situation was single piece hydrophobic acrylic lens, dial it into the bag under viscoelastic, and because I know that there is 360-degree laxity because of the pseudo exfoliation, I put in a CTR to support this, and at a later date if there is a bag IOL CTR complex dislocation, this the fibrosed bag, through the CTR you can actually hook it and suture it and stabilize the bag at a later date if needed. So that's the end of that. The last portion, I prefer not to use a Sinskey hook. I use microforceps to deliver and place it correctly. This wound can be left unsutured, or if you feel that it is not perfect internal corneal lip is not there, then you can put a suture. This is a trainee that was operating divide and conquer. Initial steps going well. First crack achieved, second crack achieved, and then change from trenching to the quadrant removal, and at this time goes too deep to the periphery, and you can see the posterior capsule has opened. How would you proceed? We want first a sutureless astigmatically neutral wound. Our second desire is to have complete nucleus and cortex removal and a AC which is free of vitreous, and complete separation between the posterior and anterior segments. So again, At this point, I have taken over, starting from within the existing wound, back cuts at 45 degrees to extend the cord length will be approximately 7 millimeters on the exterior and 8 or 9 millimeters on the interior. Since fragments are already created, it's actually a little more difficult to prolapse and get these pieces out. Gently bring a fragment at a time into the anterior chamber and deliver it using some heavy molecular viscoelastic to tamponade the area of the rent. Then judicious use of cut IA and IA cut is used to clear the anterior chamber of vitreous, and then go into IA cut to clear the cortex, and a multi-piece lens, which is desirable in all situations to have a standby, is used, placed in the sulcus with an optic capture to achieve the complete separation between the anterior segment and the posterior segment. So the optic capture ensures that there is complete separation. The haptics in the sulcus ensure that this lens will not displace. Thank you very much.
Thank you, Dr. Matthew. It's a wonderful demonstration of a very useful technique. I think, like you mentioned, it shouldn't be the first one when you're confronting a problem. You should be experienced in a normal case doing it like you said. That will be the take-home. And thank you so much. Thank you for it. Now, I call upon Dr. Anish Madhavan. He'll be talking to us about the tips to make capsulorhexis and hydro procedures easier.
So good afternoon, everyone. It's about the tips to make a capsulorhexis and hydro procedure. As you know, when you want to become a phaco surgeon, the basic thing or the prerequisite is that you should know how to do good capsulorhexis, right? Of course, there are only three things which you need to make it. One thing, the size should be adequate, it should be central, and it should be round. These are the three things you want to have a good capsulorhexis. Now, this is one instrument which I usually use. This is called a rhexis marker, which is of 5.25 mm. This is very easy because just you make an impression over the cornea, it gives a correct guide for you, and with this guide, you can very well do a rhexis. And I'll show you the rhexis. You can see the rhexis, which is very correct, well-centered, well-sized, and round rhexis. So this is a very simple instrument, and it gives you a really good capsulorhexis. Even for this is a mature catheter, here also you get a good rhexis with that impression. And maybe if you are very good, you don't need any instrument. In that case also you can do a capsulorhexis. But one thing I want to tell you is that whenever you want to make a rhexis, don't go in one shot. It is always better you make it 30 to 40 degree of tear and then move slowly, so you have a more control on your rhexis, and then you can manipulate your size, everything. So that is one thing you have to make sure that don't go in one shot. And along with that, I'll just tell you about hydro also. This is the way I do hydro. You can see the hydro, how it goes. But I usually give it 2 points, because 1 point is okay, but most of the time the other end may not be separated well. So if you give it 2 points or at least 2 or 3 points, it will be more easier for you. And there is one thing, when you do in the topical phaco, most of the time the patient will move their eye. In such cases, I think this is one thing you can do. You can have a second instrument to stabilize the eye, the globe. And if you are not comfortable to go by the main port, you can have a side port and do the rhexis, so that the AC will be well maintained in this case. And here also, I'll just show, this is for just to show the hydro procedure, nothing much to say. So you can see the wave going here. And usually after the hydro, again I said, I'll go the both side and give the hydro. And when I'm talking about the hydro part also, there is nothing much to do in hydro. Only case where you have to be careful in doing hydro is the posterior polar. So in posterior polar cataract, what I do is I don't give a hydro dissection. Instead of that, I do a hydro delineation, so that if your hydro delineation is perfect, what you see is like this. After the cataract, you see a nice epinuclear plate is remaining there as a cushion, and that actually helps you in preventing a rent. All these things everybody knows to make a capsular rhexis, but the most challenging part is an intumescent cataract when you want to do a capsular rhexis. And of course, you know there are three things you have to manage. Manage the intracapsular pressure, prevent the anterior capsular rupture, and complete a nice circular capsular rhexis. Now, otherwise, you will end up in a Argentina flag side. Now, usually what you do? Usually there are two techniques you do. This is the basic two techniques most of the people do. That is, one, you take a needle, decompress with a straight needle, and the center part is decompressed, and then after that you can extend and do the capsular rhexis. Or else, there is another technique usually people do is you make a small rhexis initially and clean it off, decompress, and then make a second rhexis. But I'll show you one thing. Now the problem I want to tell you is, in this case, you see this is how the intumescent cataract is there. This is the central area where the liquefied cortex is there. You decompress this area, what happens is, this is the original position. You decompress it, the central area will get decompressed, but the mid-peripheral area is not having the liquid cortex. It is actually a fluffy cortex, and it remains as a hill. So after the decompression, you see two hills and a flatter area. This will be the hill area, and this is the flatter area. I'll tell you what the reason for that. Now, this is a double rhexis. I have made a double rhexis. I cleaned it, everything, and now I am taking a scissors. Now I am cleaning. One second. Sorry. No, not this one. It was a small. Yeah. And now I have to work a second double rhexis. Now I am taking a vannaz and cutting. See what happened. So I did everything. Then what went wrong? The thing which went wrong, I'll tell you. This is something I personally feel, this is called the hilltop runoff, because the central area I have flattened, but still that you have seen that mid-peripheral there is a hill. So here you see the moment, now I am doing the rhexis, I decompressed everything, and now I am doing the rhexis. See, the moment I enter into that hill area, my rhexis gone into the hill area, there will be a slope on the other side. Whatever you do, I am 100% sure that it will extend. It will extend towards the down. Otherwise, you have to keep your rhexis within the valley. You never go into the mid-peripheral area. See, it's gone. And now I will show another video which I have already completed my rhexis. And here you can see see, here again that mid-peripheral area has come up, and here you see a rhexis run over. So I personally feel that what you have to do is, whenever you have a intumescent cataract, after you decompress it, take any instrument, whether you have a Sinskey hook or your hydro dissection needle, whatever it is, you just flatten this area. You have to flatten this area, remove this fluffy cortex from here, and make the whole anterior capsule flat. And what you can do is like this, after that you make a plateau creation. See, go under it, even with your hydro needle you go under it and just remove all the fluffy cortex from there, make the whole rhexis, the anterior capsule flatter. Now you see, even I am making a bigger rhexis. This is a bigger rhexis which is going into the mid-peripheral area, but still you see nothing is happening. You get a very controlled rhexis in this case. So this is one tip I want to tell you when you want to do intumescent cataract. Always flatten it, just break the hill, make it a plateau, and do it. So decompress the center, flatten the hill, and milk out the mid-peripheral cortex, and always use a blue. Thank you.
Thank you, Dr. Anish. I think the take-home messages from this talk is that we should make an adequately sized rhexis. Don't make the rhexis very small, then bringing out the pieces will be very difficult. And also you should have a very good cortico-cleavage hydrodissection so that the nucleus management becomes easy. And also while rotation it causes less pain. And also as far as the intumescent cataract is concerned, if the cortex is very loose, everything comes out very fast. But if there is a fluffy cortex, as shown here, what we can do is after making the primary rhexis, don't again hydrodissect because it will increase the back pressure. So you can take an iris repositor or a spatula or something and just loosen up the cortex. And then if you aspirate, it comes out very fast. And also the back pressure means it comes out very fast. You can reduce the back pressure and then go for a secondary rhexis. And also while making a secondary rhexis, don't make a radial cut. You have to make a slightly sloping cut sort of thing so that it suddenly doesn't extend. And also another thing is, suppose it extends, you don't inject viscoelastic in the center, so that causes further extension of the rhexis. So inject the beyond the periphery of the extension, and then you will get a better control. And also you can use the Bryan's little technique. So these were the few take-home messages from this talk.
Thank you. Now I invite Dr. Minu Mathan to talk to about the PC rent management during topical Phaco. Golden tips in going ahead. Dr. Minu, please.
Thank you, Dr. Soni. Many of the steps have been shown by Matthew Kurian, and we'll just see. Topical is different. When you are doing topical, it is slightly different from under block. Under block means you don't have to care at all whether patient will get pain or not. Your steps have to be proper. But then if it is topical, your steps also have to be proper, and also the patient should not feel that there is something wrong or extra going on, causing some irritation or pain or discomfort. So manage that part first and then go for your, anyway it's going to take some more time and some more different manipulations than what you normally do for a Phaco. So you would be okay with the manipulations in Phaco to adjust it according to what you are comfortable with to make the patient comfortable. But the other thing is you got to get a vitrectomy probe, you got to extend, all those things. If it happens, you need to have the patient comfortable first. So add on intracameral lignocaine 1% preservative free, or give, as Dr. Sandhya showed, subincisional lignocaine, or give a little, after giving a little subincisional or subconjunctival, and then give a subtenon's block, and then continue if patient becomes uncooperative and painful. If you should keep watching, don't ask whether you have pain or not. Then they will think, why is he asking for pain when I don't have pain? So look for signs of patient becoming uncomfortable, squeezing the other eye, moving the eye, and all those things, and somehow they will move their leg like this, fold. All those things are signs to make you feel that patient is getting more uncomfortable. So during all these steps, you can have posterior capsule rupture. And in some cases, you can have eye movements helping you. See, when you have a PC blowout, and you're thinking what to do, okay, you'll take out the Phaco probe. Then patient will also just adjust his eye and help you in letting your nucleus just fall off, you know. So that also can help if you do topical anesthesia. So there are different ways patients can help you. So on a lighter mode, then see, once you have comforted the patient, then the standard principles of PC rent happens. Do not withdraw. Identify your posterior rent, posterior capsule rupture, and then stop irrigation and don't withdraw. Don't shallow the chamber. Put in dispersive viscoelastic. Identify your rent, and if it is small piece left, extend the corneal incision. That is easier. So it doesn't cause much of pain. You don't have to cut conjunctiva. Close your incision. Do a bimanual vitrectomy. Vitrectomy through non-leaky wounds. And look at the peaking of rhexis or the rent margin. That shows you that there is vitreous there. You can use triamcinolone. I will show you. And if small bits are left, do dry aspiration like this. So after doing a vitrectomy, you can use the vitrectomy probe itself to aspirate the rest of the cortex by making it into IA mode. Change it off to IA mode. And if vitreous comes, make it a cut IA, change it to eye aspiration and then cut. But that's a little difficult. Change it to an aspiration mode. If you get vitrectomy, change to vitrectomy mode. This is triamcinolone. Little bit of triamcinolone where you have doubt. If you pour in triamcinolone, even if it's diluted 1:5 or 1:4, it will go directly into the vitreous. After doing a vitrectomy, it will cause intractable glaucoma and all those things later. So don't pour this one so much of triamcinolone should not go into the vitreous. That is the point. Here again, doing a PAL. Again, you have to anesthetize the conjunctiva by giving a subconjunctival there, and then only cut conjunctiva. Conjunctiva touching is always painful, whatever anesthesia you give topically. And then here it's a mature cataract. So mature cataracts can have this posterior polar cataracts hiding behind. So please look at the posterior polar cataracts, when you chop this, you see that central white zone there. It will become more prominent now. If you can notice the central white zone. So if that is there, be careful in rotation. See, I don't find any problem, so I am keeping on chopping. But see, look at this nucleus half. It is almost disappearing on one side. That means the PC is open and it is tilting. So at that point, I stop, put in viscoat and plug that area and bring the nucleus up. Reduce the aspiration flow rate. That is most important. Should not be aspirating here and there. And then do a controlled slow motion phaco. Still no vitreous prolapse. So now you can see the central large opening. This posterior polar typically gives this railroad kind of opening, and I prolapse the rest of the nucleus into the anterior chamber. Put in again viscoat, and then take a 3-piece IOL. All mature cataracts or whatever case have a 3-piece IOL backup, and that goes on top of the iris. If you are sure that your rexus is fine, it can go under the iris, but you can put it on top of the iris. Then don't think that you don't have space. There is enough space. Put a lot of viscoat into the anterior chamber. Do it slowly. Not that gross chopping should happen. It should be mild chopping, small pieces you make, and gradually aspirate. You don't have the scare of nucleus beads going into the vitreous now because the IOL is scaffolding. After that, to dilate your pupil and then see for cortex, and then use the vitrector. Even if you don't have a vitreous prolapse, I do a vitrectomy there to take off all the viscoat, because a lot of viscoat has been pumped in, and that if it stays there can cause unnecessary iritis in glaucoma and all those things. So I use a vitrectomy probe to aspirate, and as and when vitreous comes, you aspirate the vitreous also. Again, as Dr. Sandhya was showing, when you are aspirating cortex from the PC, you can get a PC rupture, but then don't take out your irrigation. Stop there, and patient will squeeze when you take out irrigation, shallowing, and then that's enough to open up the PC completely. So keep the irrigation there, and then inject and form the chamber, and then only take out your irrigation. So this is not a topical case, but I'm just showing you where you can have a PC run. See, this kind of shooting in of foldable IOLs, or this haptic, which is turned the other way around and it is sweeping across the PC. Then also that can cause a PC rupture if you do not load the lenses properly. Here again, this is the problem here. See, if you notice here, the lens which is loaded improperly, or when the injector tip, plunger tip overrides the optic, then you will feel more pressure and you will give more pressure, and suddenly it will give way. So this is what happens when these kind of lenses fly in. And then the patient is under topical, but then definitely there is a PC run there. But it will be a small one. I don't have time to show all those. So there's a small PC rupture there, and I turn the IOL into the opposite direction. The haptics are kept vertically, and then get away with it. And the last thing is the cortex aspiration. When you turn your tip down and inadvertently catch, you know where your reflex button is and hit your reflex button. Without knowing reflex button, where the reflex button is, don't do phaco. Remember where it is. And the last point is, the small opening in the posterior capsule here. If you think that shallowing the chamber will cause extension, overinflation will also cause extension. See, look at what I have done. I have overinflated. See the helon coming out. See the PC which has opened up completely. So don't hyperinflate also. I'll show that once more in slow motion. This is the large opening which has been created because of hyperinflating the anterior chamber. So this becomes such a big rent just because you have hyperinflated. And this is just to show this can be. Thank you very much. We don't have time for all those.
Thank you, Dr. Minu, for showing us the management in various PC and in various forms of topical phaco. And biggest points to be remembered again is not to withdraw. When you see the earlier signs of a PC run, you shouldn't withdraw. Always inject OVD and plug the PC run from vitreous coming up. And second again, overinflation also can lead to extension of the PC run.
See, one point, Sonia, I wanted to tell about the injection of the lens. Whenever we inject through this small instance, I nowadays lift up the anterior lip and then put the injector tip. When we drag conjunctiva along, when you are trying to inject the tip, then it pains. So I put it in the section, lift up, and then put it in. Doesn't drag, doesn't pain much. That's what I have noticed. I thought initially because of the stretching of the incision. It's not so. Stretching of the incision causes nothing. It is the dragging of this one. And as you showed, I nowadays don't catch the conjunctiva. I am using a MVR now. So MVR, once it enters, even you can even fully enter. The round rod blocks the whole paracentesis, and then you can make the clear corneal incision. But the 15-degree blade, the problem is that sometimes when the patient moves the eye, you can cut through. That is one thing. The other one, you don't have sharp ends.
Sir, just one doubt, sir. In this case, did you put subtenance silocaine or just subconjunctival silocaine?
Where? Which one?
When you converted.
No, converting, see, depends on where you are going to cut. If you are just cutting locally, you need to only this one. But if your patient is having pain while doing intraocular manipulations, then the subconjunctival will not work.
So
We will have to have a subtenons only.
If you're giving, which quadrant will you give, sir?
Infranasal.
Infranasal. Thanks.
Thank you so much. Are there any questions from the audience? Any comment from Dr. Matthew? Okay. Thank you all for patient listening, and I thank each speaker for agreeing to participate in this instruction course. I definitely feel it was a very useful course, and thank you each one of you for the wonderful tips given in, especially for people aspiring to convert to topical Phaco. I would request all of us to have a group photograph and to collect the certificates.